Hey everyone, and welcome to this explainer. I am absolutely thrilled you're here. Consider this your shift handoff. Today we're going to walk through 5 high-yield, critical clinical scenarios that will literally sharpen your surgical reasoning overnight. Whether you're prepping for the wards, gearing up for boards, or honestly just looking to solidify your clinical decision-making, we're going to break down these cases step by step. We'll look at the presentation, the diagnosis, and the absolute crucial management reasoning for every single one. All right, let's just dive right into our patient list for today's ward rounds. We're going to tackle each of these 5 high-yield scenarios back to back. Acute abdominal pain, a postoperative fever, retrosternal chest pain, post-surgical hypotension, and finally, a really tricky case of pain that's completely out of proportion to the physical exam. Okay, case number 1, acute abdominal pain, specifically appendicitis. Let's get right into the emergency department mindset. So here's your first vignette. Picture a 45-year-old female who comes in with sudden onset, severe abdominal pain. It's totally localized to the right lower quadrant. You do your physical exam, and you immediately note rebound tenderness and guarding. Her vitals? Well, they're currently stable. Based on these classic hallmark signs, what's your mental diagnosis right now? Lock it in.
Boom! If you guessed acute appendicitis, you hit the nail on the head. Now, the really critical emphasis here is on the pathophysiology, specifically luminal obstruction. Whether it's from a fecalith or a lymphoid hyperplasia, that blockage is the primary driver of the localized inflammation. You know this is a surgical emergency, right? Understanding that luminal obstruction dictates the need for prompt intervention is absolutely crucial to prevent complications like perforation and peritonitis.
But wait, what if she had presented with a fever, leukocytosis, and a CT scan showing a periappendiceal abscess? Well, the management logic completely shifts when the case gets complicated. We don't just rush her straight to the operating room for an appendectomy right away. The standard of care shifts. Step 1 is getting intravenous antibiotics on board to control the systemic infection. Step 2 is percutaneous drainage of that abscess. You drain and stabilize first. Only after the patient is cooled down do we move to definitive surgical intervention.
Moving on to case 2, postoperative fever, focusing on atelectasis. Let's head up to the surgical ward and see how this builds our post-op reasoning.
Okay, picture this. You've got a 65-year-old guy who just underwent a laparoscopic cholecystectomy. It's now postoperative day 3, and out of nowhere, he spikes a fever. You examine him, his surgical wounds are totally clean, showing 0 signs of infection. He has no respiratory symptoms and no urinary symptoms, no burning, no frequency. So we can pretty much rule out a wound infection and rule out a UTI. So, what is the most likely cause of this fever?
The main takeaway here is that without any other localized symptoms pointing elsewhere, incomplete lung expansion, which we call atelectasis, is your most common culprit. It's incredibly common after surgery, particularly abdominal surgeries. Why? Because the pain might literally prevent a patient from taking those deep, clearing breaths they need.
This timeline is a total lifesaver for pattern recognition. Day 0 is the surgery itself. When a patient develops a fever, specifically on postoperative days 2 through 4, it highly points toward atelectasis. Recognizing this timeline helps you avoid unnecessary panic, and more importantly, guides you towards simple interventions, things like getting the patient up and walking or using an incentive spirometer, rather than just immediately jumping to broad-spectrum antibiotics.
All right, case 3, retrosternal chest pain, looking at Wehrhoff syndrome. We're transitioning to a super high-stakes, trauma-like presentation for this one, so get ready to think fast.
You've got a 60-year-old male rushed into the bay with severe retrosternal chest pain. He's got a history of forceful vomiting just right before the pain started. On your physical exam, you feel this weird crackling sensation under the skin of his chest. That's subcutaneous emphysema. Those 2 buzzwords, forceful vomiting and subcutaneous emphysema. What are you thinking? What's your diagnosis? Yep, let's dive into Boerhaave syndrome. Now, the absolutely crucial distinction you need to make here in your clinical reasoning is that this is a full-thickness rupture of the esophagus. This isn't just a Mallory-Weiss tear, which is a mucosal laceration causing bleeding. Because the rupture goes entirely through the esophageal wall, gastrointestinal contents are literally spilling directly into the chest cavity. This makes it an absolute life-threatening emergency.
So, mechanically, what's happening? That massive spike in intragastric pressure from forceful vomiting just pops the esophagus. The air escaping into the tissue is what causes that subcutaneous emphysema you felt. But the real core surgical imperative here is that escaping gastric acid and bacteria will rapidly progress to severe mediastinitis, which is a catastrophic infection of the mediastinum. You have to recognize this instantly to secure surgical repair and prevent full-blown sepsis.
Down to case 4, post-surgical hypotension, dealing with abdominal compartment syndrome. For this one, we're moving straight into the ICU setting to deal with a rapidly deteriorating trauma patient. So this is a 60-year-old guy who recently had abdominal surgery following some pretty severe trauma. While in the ICU, he suddenly becomes hypotensive and tachycardic. You do an exam and find his abdomen is severely distended and really tense. His organs are failing. What is the very next vital measurement you need to take to save this patient's organs? The highly testable diagnostic threshold you absolutely need to burn into your brain is greater than 20 millimeters of mercury. We are talking about intra-abdominal pressure. When the pressure inside the abdominal cavity exceeds 20 mmHg and it's accompanied by new organ dysfunction, well, you've officially diagnosed abdominal compartment syndrome. The pressure is literally choking off the blood supply to the kidneys, the bowel, and even returning blood to the heart. Which brings us to the definitive treatment logic. Step 1, as we just saw, is to measure that intra-abdominal pressure, which you usually do via a bladder catheter. Once you confirm it's above 20 millimeters of mercury with organ dysfunction, step 2 is crystal clear. You cannot just give fluids or vasopressors here. You must surgically open the abdomen. An emergent decompressive laparotomy is really the only way to relieve the pressure, restore organ perfusion, and ultimately save the patient's life. Last but not least, case 5, out-of-proportion pain and acute mesenteric ischemia. This is a classic presentation that requires incredibly sharp clinical suspicion. Here's our final vignette. A 70-year-old guy comes in practically screaming in agony from severe abdominal pain. You glance at his history, he's got atrial fibrillation. You run some labs and you see significantly elevated lactate levels. Based on that history of AFib, which, as you know, is notorious for throwing clots, and the lactate indicating tissue starvation, what is the diagnosis? So the crazy thing here, the absolute hallmark of this condition, is a stark diagnostic discrepancy. If you press on this patient's abdomen, your physical exam might be surprisingly benign. I mean, it might be soft, without much guarding or rigidity initially, and yet the patient is in absolute agony. Pain that is wildly out of proportion to what you feel on the physical exam, especially in a patient with a thromboembolic risk factor like AFib, is the classic textbook presentation of acute mesenteric ischemia. To pull it all together, a clot has essentially lodged in the mesenteric vessels, causing inadequate blood supply to the intestines. The bowel is dying. That's what causes the agonizing pain out of proportion to the exam, and the starving cells are switching to anaerobic metabolism, which spikes your lactate. This is a massive surgical emergency. Prompt intervention is required for sure, often a surgical embolectomy or a bowel resection to prevent irreversible, fatal bowel necrosis. Which leaves us with a huge question for you to take back to the wards. In your next clinical rotation, when you're the one doing the exam, will you be able to recognize that silent mismatch between a patient's screaming symptoms and your quiet physical signs before ischemia turns to irreversible necrosis? Keep these 5 high-yield scenarios in your mental toolkit, trust your structured reasoning, and you'll be more than ready for the clinical challenges ahead. Thanks for joining me on this explainer, and I'll see you on the next shift.